for our weekly Endocrine Multidisciplinary Conference, or Endocrine Grand Rounds. And today, we're very happy to have Tom Walton to speak to us about basic needs in diabetes, a discussion. It is kind of an unusual topic for us, but at the same time, it is a very important topic, and that's why I chose this. Long ago, I was told that if you have to make a big impact on anything, any disease, you either do a basic discovery that will change the understanding or treatment, like if you discover insulin, then it'll have an impact, or you should be in public health where you can impact a large number of people rather than what we do, which is one patient at a time. So thought this is very important. I have known Tom for the last few years and was very impressed by his grasp of the public health issues and how socioeconomic factors and health disparities have an impact on how we manage our patients. And we deal with it every day, but we don't pay much attention. We want somebody else to deal with it. But it's the thing that we always have to address. So I thought it would be a nice thing to for him to talk to us. He's very knowledgeable about this and can summarize it very well. He is currently executive in residence in the School of Public Health and Information Sciences. He has been at UofL for a long time, I think from being a student to working in various capacities at University of Louisville Hospital, the Population Health Program. Currently, he's also the Chief Operating Officer at the Traeger Optimal Aging Institute. So he wears multiple hats, and he also is involved in a number of community projects, which are both in the city and statewide, and many of them have impact on obesity and diabetes. So I think it'll be wonderful for us to hear from him about a very important topic, basic needs in diabetes discussion. So.
Well, good afternoon. I don't know if everybody tells you this, but it really is helpful if you ask me questions as I go along. And what I'm going to do is paint a very broad picture of how diabetes can be addressed using the socio-ecological model, but also tell you about some of the work that's going on both in Louisville and around the state to address diabetes and obesity. So it's a disclosure statement. I always like to start talking about health equity. This presentation was originally prepared way before the pandemic and the civil unrest that we have right now. Again, I'm not a big reader of slides, but if you could just see what equity is, we're very, very important in that. As a matter of fact, one of the focus areas of the Foundation for a Healthy Kentucky is to take an equity lens on all of our work now. I represent the university on the Community Advisory Council, so we're thinking always, so how is equity impacted by the decisions that we're making? This one is a little bit different, hard to grasp for probably a direct clinician, but an asset-based community approach, this whole sort of body of knowledge developed in the work in the area of community development. And so there is an asset-based community development institute that started in Northwestern, now it's at DePaul, but let me get rid of this here. But again, whoops. Well, we'll just go from my memory here. So anyway, what asset-based is, and frequently, and I'm going to apply this to diabetes, when you're working with an individual or family and you think, well, they're, if you use the term non-compliant or not adherent, instead of saying, well, judging them, you go back and say, well, what resources do they have to become more compliant? You know, what's their neighborhood situation like? What sort of resources? A really good example of asset-based is the Dudley Street Project in Boston. And they started off thinking Well, Boston started off with basically citywide codes regarding housing. And then the people from the Dudley Street neighborhood said, wait a minute, we really know what's best for our neighborhood. So again, they incorporated and adapted some of the citywide codes to their specific neighborhood. So they in fact could govern how their neighborhood developed in terms of community centers and schools, et cetera. So they're taking an asset-based approach to that. The next is culture. Again, not going to read the definition, but a good example of that is the neglect of culture. In other words, if you're working with a family, an African-American family, and you prescribe a diet that they purely cannot afford, they're going to reject that diet. So there's some work emerging in an African-American plate. And again, I don't know how much of this work you know or whether you're just focusing clinical. So my apologies if you're already familiar with some of this work. So again, sort of ground setting there. Here is the socio-ecological model in true transparency. There's lots of different versions of this out now. This particular version is used by the Center for Health Equity at the Louisville Metro Public Health and Wellness. And each year, actually kind of every 2 to 3 years, they produce a report called Health Equity Report, and they use this socio-ecological model to frame that. And again, we'll get into more definitions a little bit later. I do need to confess that I've added private policy to that, and the reason for that is I went to a lecture by somebody from Walmart's health enterprise a few years ago, and he talked about the greatest jump in medication adherence when Walmart started adding, $4 prescriptions. So again, and then if you have a company like a large employer that decides to cover diabetes prevention programs, that's a policy decision that can be made at the organizational level. So here are the levels of intervention. Again, not going to read it. And again, as you started off, I think you all mostly function at the individual level. We're going to talk about interpersonal organization, this private policy that I can talk about, and then community and public policy. A good example of private policy, there's a group called the Democracy Collaborative, and what they're doing is they have they're supporting what's called the Healthcare Anchors Network, which is some of the largest not-for-profit health systems in the United States. We're talking like Common Spirit, which is a merger of Catholic Health Initiatives and Dignity Health, Kaiser Permanente, Rush are all in this. And what they're doing is they're going at and looking at how they can hire, buy, and invest local. And collectively, they've dedicated over, I think it's up to $700 million to developing affordable housing in the communities where they sit. In Louisville, let me just talk a bit about some of the starting at the private policy. I've given an example of that. We're actually seeing a lot of that these days in investment in the West End, where Norton Healthcare decides to, devote, I think it's $5 million to the track that the Urban League is building. The community, we have a really unique opportunity here, which I'll touch on in more detail in a minute. But yeah, I'll just wait a second. And then public policy. So here's a big question for you all. What do you think is the most significant public policy decision that was made in the last 10 years in Kentucky?
Medicaid.
Right, it's to expand Medicaid. Okay, let me give you sort of a concrete example from this. And when I tell people about career, I basically sort of round things off and talk about fives. So I was with Humana's corporate office for 5 years when they still had a hospital division, and my focus there was productivity and efficiency. So you're going to see that sort of cascade through a lot of what I talk about. Then I was at University Hospital 20 years in a variety of roles, including access, quality, scheduling, et cetera. Then 5 years with Kentucky One and CHI when they were part of this, here in Louisville as Director of Population Health. And then also I spent some time as the Director of Business Development for their Accountable Care Organization. So asking about value-based care, I can give another really interesting talk on that. And then 5 years with the university, and a little bit more detail, but what an executive in residence does, that's my most common question. I spent about half my time at the Traeger Institute, and the optimal aging clinic doing really hardcore operational things there like scheduling and all that. And part of the reason I keep doing that is it keeps me very well grounded in the way the American healthcare system is operating. The other half I do spend representing the university on coalitions, and then I co-teach leadership and population health class. But anyway, back to my days at University Hospital. This is in 2012. And we were looking, this is a pre-Medicaid expansion, and so the hospital was governed by the Quality and Charity Trust Fund, which was basically a pot of money in the neighborhood of $25 to $27 million. And the guarantee was that they would take care of all the uninsured population of Jefferson County, but in reality it cascaded out to much of the state of Kentucky. Anyway, we had one gentleman, I'll call him Joe, who was experiencing homelessness and was in UofL's ER 223 times in 1 year. And if you looked at his 2-year history, he had been there over 500 times. Well, clearly that's an unsustainable. I mean, that was good for nobody. And it wasn't good for Joe, wasn't good for the hospital, it wasn't good for Joe's family, et cetera. So what we did is we stopped thinking at the individual level and always delivering clinical care like we had done in the past, treat and street like they do in emergency departments. And we said, so what's really going on with Joe? And so we had our care management staff really take a deep dive into his medical record. We talked with the Phoenix Healthcare Center for the Homeless and a lot of other community organizations. What we decided that would really be helpful, and Joe was frequently found down, which is, you've probably seen that diagnosis on our chief complaint on a lot of ER visits, which meant that in fact he was being brought there by EMS. The police are frequently called, so it was a very high resource individual. So what we decided to do is we had convened this group called the Community-Wide Complex Case Treatment Planning Conference. So it had all these groups. It had the Phoenix Healthcare Center for the Homeless, 7 Counties, which is a local behavioral health organization. Metro Corrections was there, EMS, Our Lady of Peace, just this coalition for homeless, a large coalition. And we presented Joe's case in a de-identified manner. And what we decided to do is, in fact, to do 2 things. One, Kentucky has a Casey's law, which allows you to involuntarily commit somebody to drug and alcohol treatment if you agree to pay for it. So we were going to do Casey's law, and then we identified a site in northern Kentucky that took care of people experiencing homelessness with substance use disorders. So anyway, we kept him in the ER. We broke all those organizational policies about getting people in and out of the ER quickly. I think he was there about 3 days. But anyway, once he was sober, he was served to go and appear before a judge to have this committed to Casey's law. And University Hospital had made the decision to pay for his treatment at that point. Technically, the judge threw out the case, but she said to Joe, if I see you in my court again, I'm going to rehab you in jail. So he agreed to go to this treatment center for 3 months. While he was away, I'm moving up to the community there. We arranged for him to come back into a permanent supportive housing environment. And by the way, if I use any term that you are not familiar with, just sort of stop me and I'll be glad to explain it. And the reason I do that is I've discovered that the same term in different environments means very different thing. My primary example is diversion. In the hospital world, diversion bad because you're turning away ambulances. In the corrections world, the criminal justice world, diversion good because it means you're diverting somebody from incarceration. And in the substance use world, diversion bad because it means you're usually diverting a substance to an illegal use. So please stop me if I use terms that are not familiar to you. So anyway, Joe went to this treatment center. He did really well there. He came back. And so the way we looked at our data is the base year and then the intervention year. So in the intervention year, Joe had 10 emergency department visits. And again, in the base year, he had 223. We did a little back of the envelope kind of cost analysis and looked like the hospital avoided spending about $140,000. So again, this is pre-Medicaid expansion, so that's a very significant. The reason I talk about this is when you think about care for people with diabetes, if you only focus on the individual or even the interpersonal, which I would most commonly think was the family, is that kind of correct? Yeah. then you might be sort of missing the bigger picture. Now I'm going to talk about the Louisville Health Advisory Board, and my language is very careful here, that Humana convenes the Louisville Health Advisory Board as part of their bold goal work. And their bold goal was to improve the health of the community 20% by 2020 and thereafter using a variety of approaches. So I think they're up to like 14 or 15 bold goal market, and each of those, like Tampa or San Antonio, has an advisory board. I point blank asked them, so are you comfortable having your competitors on the participate in this group? And they said yes. So in the Louisville, I co-chair the Community Coordination of Care Committee, so we have Aetna and Anthem and Passport. I mean, they're direct competitors. The goal really is to improve the health of the community. And Humana, I'll get to this a little bit later, has taken a very strong stance toward addressing the unmet basic human needs, commonly called the social determinants of health. And they also are taking a very strong stance toward equity. And I can, send you all links to papers that they've produced that explains their approach. I call the Community Coordination Care our constellation of peoples, programs, and passions. And this is very important because many of the coalitions that I go to are purely health coalitions. But in this coalition, on this Coordination of Care Committee, we have the housing sector, the Metropolitan Housing Coalition and New Directions. We have Dare to Care. We have Jefferson County Public Schools, Norton Healthcare, UofL. I mean, lots of these different groups who represent the payers that I alluded to before. We talk about all these different programs, and then we have all these little passions. And that's because many of us have a long history in advocacy work, and so we have certain things that we're very, very interested in. The committee has 3 work streams. They are to screen, and we are very fond of screening for unmet basic human needs. And I use that term, not social determinants of health. And the reason for that is that when you have all these different sectors represented, I mean, to kind of paraphrase it, they said calling it the social determinants of health is self-referential to health. It's really the determinants of health and well-being. It's much broader than that. They also had some objections to using the term determinants. Some people prefer influencers or correlates or things like that because, again, we all know that people can thrive in very unfortunate situations. So, again, we very much push for screening for these unmet basic needs. We typically screen for food, housing, transportation, interpersonal violence, utilities, housing. There are lots of tools out there that are being used. The one that we're very fond of is called PREPARE, P-R-A-P-I-R-E, from the National Council of Community Health Organizations, which is basically the federally qualified health centers, because it's pretty comprehensive, is easy to use. The second, we realize you can screen, but unless you can navigate some of your resources, it doesn't do much good. So there, in this sector, we were doing a lot of thinking about how to navigate people to the most appropriate resources. At the same time, the Jefferson County Education Coalition, which has really heavily influenced the behavior of Jefferson County Public Schools, was thinking how to navigate their students. Well, fortunately, the Metro United Way stepped up to become the backbone organization for an effort that's now called United Community, which uses a technology called Unite Us to make these sort of navigations. So again, you can enter the the family health centers. They're going to put your data and say, oh, Tom has a need for housing services. They're going to put that into the system, and then organizations actually respond to it. It also gives us data, so we can see what the articulated needs are. And just sort of as a side note here, with the pandemic, Louisville faces about a need for there'll probably be like 30,000 evicted families that we're looking at. So they're using the United Community System to sort of navigate people into eviction prevention services. Since I mentioned that, I'm going to do a quick aside here, and to go back to this people and passions, because the housing people are on this committee, we know that in Louisville we need 412 additional affordable housing units for people living at 30% of the area median income. So again, that's why we're taking this big approach. The third thing, our third work stream, is to increase capacity and coordination. And again, you can screen and you can navigate, but if the resources are not available, you have not helped the individual. I actually just added coordination last month because we spent the majority of our meeting talking about all of these eviction prevention services that are now coming online, and it's very complicated, and there's shifting around. For example, there's an association of community ministries and the Urban League. We're doing some eviction work, but because the funding came from Housing and Urban Development, they had to use a system called the Homeless Management Information System, which they didn't want to use. So all that funding sort of shifted over to the Coalition for the Homeless so they can do that sort of navigation. That's the sort of thing that talking with people about food and then housing, and I actually spend most of my time in the housing sector. And what we decided to do there is we know because of these national efforts going on, and again, an article just came out yesterday, thank you for referring it to me, on diabetes care that walks through a lot of the housing sector, and a lot of other unmet needs, so I'm not going to spend a lot of time there. But anyway, what we chose to focus on is the effort is called a Housing is Health Initiative, because we know that there's strong correlation between housing and, diabetes care and all that. But anyway, we are also really practical people, so we chose to focus on one project and call it Respite to Residents, and those are people experiencing homelessness being discharged from a hospital. One study showed that if you it was in Boston, that 70% of the people experiencing homelessness returned to the hospital for some sort of care within the first month after discharge. And again, Medicare just released its readmission penalties. So this has a direct financial implications for the financial health of hospitals. So anyway, what we're going to be doing, and we had our first meeting 2 weeks ago, where we had our first statewide meeting 2 weeks ago, and now we're in sort of a design phase, but we're looking at how do you take people experiencing homelessness being discharged into a safe respite environment, and then using that respite time as a point of entry to a 12-month process to navigate them into more permanent supportive housing. We're very interested in the lived experience, and I use the term lived experienced experts to make sure that we capture their insights. A good example of that is we had a professor from Spalding go out and actually interview some people experiencing homelessness, and her presentation started with a slide of a tent and somebody who had recently been discharged post-surgery was living in this tent. So you can imagine he had no resources to clean his wounds and stuff like that. So he had been returned to the hospital multiple times. But unless we hear that, and again, in your world, I don't know how much time you can spend in a clinical encounter. I'm really aware of E&M coding and times and all that. But to understand the stories of the people that you work with, I think it really will inform our care. The second group we're working with is what we call the practitioners and the payers. An interesting point here is we call this the wrong pocket problem that we're trying to address. An example of that would be if you ask a hospital to add more case management staff. However, the savings from their increased case management accrues to the like a Medicaid managed care organization actually paying for the care. That's the wrong pocket problem. So again, we spend a lot of conversations. How do you harmonize the flow of funds so that the resources are delivered to the person and family in need, and it makes then there's financial sustainability there. And then lastly, and this is probably where you all fall as the researchers and the informatics, we just really know that there's lots and lots of data out there, but we really have not captured it effectively on the social determinants or the unmet basic human needs and its impact on there. This is my public health slide, sort of mandatory these days, but just to show you how we really are shifting away from, public health as an individual event to looking at multiple sectors. And just I walked through this example of the Louisville Health Advisory Board to tell you how multiple sectors are coming together to do a collective impact. It's sort of my dream that we form this kind of collective impact really focused on the people with diabetes and their families and their communities so that we really can coordinate the care better. Again, just another slide to talk about Public Health 3.0. And if you'll look to the right part of the slide, the bucket number 3 is these interventions that reach whole populations. And we talk about food security. That's the sort of thing that we're talking about. I was at a meeting several years ago, and David Jones Jr. was talking about the cost of calories and that, snack cakes and donuts and all that have a much lower cost of calories. And so that really does drive. I mean, do you all see that sort of in your populations that you work with? Yeah. Yeah. And again, if you have hungry babies, you're going to want them to stop crying because they're hungry. So this is a number just to give you the example. People don't really realize the magnitude of diabetes and pre-diabetes in Kentucky. I should say the general population. I think many of you probably do.
The city of Louisville population, right?
Yeah, it really is. Yeah. Now I'm going to talk a little bit about emerging trends and technologies, and we're going to use the socioeconomical things as my sort of frame of reference. And again, do you all do research? Are you really focused on clinical care or clinical bench research? What is?
Mix of clinical care and clinical research.
Okay. So again, this is some of the stuff that we're seeing in the literature. And again, I think if you want, you can have copies of the slides. But this program, again, I can think in big picture kind of things. So what this study found is that for these medically tailored meals, they reduce the per member per month cost about $500. The program costs about $300 PMPM, so it's a savings to the payer of about $200. Do you all think about things much from the payer's perspective?
There's no time to think.
Yeah.
You'd like to.
Yeah.
There's no time.
Yeah, there's no, but anyway, that's the way, when you talk to an insurance company or a payer, you really have to think, I mean, you have to know in your mind that they are always translating everything they do into a per member per month cost. Even annual wellness visits, they're very interested in improving the health of their members, but they also know that if they have an accurate picture of the patient's condition, it impacts their reimbursement from Medicare in the Medicare Advantage plans. Certainly the same thing is true in the Medicaid managed care organizations. The next, again, this from Health Affairs is food insecurity and health outcomes. I think you all are really, really well aware of this. This is one of the reasons I inserted the private policy in as a sort of a separate socioeconomic level, is work schedules can have a big impact. And again, I think probably sleep and, stress, I mean, all those things sort of contribute. This is one of the papers that Humana just produced. This one is on a value-based care report. And I've included this slide, particularly if you look at this last paragraph, you can see that they're taking an integrated approach to address physical behavior and social factors that play a critical role in promoting better health outcomes. And they really are very, very interested in this. And again, they're going back and doing a lot of data analytics on their population. So that's where they get this 91% have at least one chronic conditions. The next, again, I don't know if you can all read that, but this is from another report, the Bold Goal Progress Report. And the three things that they're talking about at the bottom are tackling food insecurity. And again, I can see their thought process becoming more and more comprehensive. Typically, I think when they first started several years ago, they talked about having food pantries and primary care offices and things like that. And now they're expanding the scope, as most people are, to look at food security as a larger kind of societal issue. Addressing loneliness and social isolation, they have formed a strategic partnership with a company called PAPA, which basically pairs college students with older adults for comfort. There's some work going on. I don't know if Humana's doing it, where they're actually co-housing like undergraduates in skilled nursing, in nurse independent living. In fact, the Presbyterian home, which is here in Louisville, where the Dr. Furman is the medical director from the Optimal Aging Clinic, I think they're building some independent living apartments, and 5 students will be living in those apartments. And then improving access to transportation. Oh, I forgot to tell you that TARC is also representative on the Louisville Health Advisory Board Community Coordination of Care Committee. Their director of strategic planning, and she has a very interesting perspective. They really are moving to seeing themselves as a mobility hub. And I asked her in one of our meetings, so are you thinking TARC is going to control all this? And they really are not. What they're talking about is establishing, they use the term of mobility, a mobility ecosystem, where they link like Lyft and Uber and all these other kinds of things together. And then a lot of companies are starting to use Uber Health, either to bring people to doctor's appointments or to deliver, telehealth equipment to actual apartments, to people's homes, so they can do that work. And then in the diabetes world, the name of the company slips me right now, but basically it's out of Chicago, that's working with Rush Health System. And what Rush determined was they saw an increase in ER visits of people with diabetes in the last week of every month. And so they are working with this company so that on the 3rd Sunday of every month, they're dispatching a Lyft driver. And then as soon as they receive acknowledgement that that person is en route to a grocery store, they put like $40 or $50 onto a debit card. And what they determine is that, the last week of the month, people's supplemental nutrition benefits have run out. And so what they want to do is have them the ability to buy food to sustain them the last month. And again, that's part of the thinking behind moving to value-based care, is that you're at risk for the outcomes of the population. So you have some encouragement to be more engaged with them. In the spirit of making sure that it's not just Humana here, but Passport is also thinking about this. We're doing some work in our Housing as Health initiative with the United Health Group, and they have invested over $500 million to address. Actually, I think they've done that just with housing. So they want to build affordable housing, and they're developing 2 examples of that. One is they are working with public housing authorities, and one of their health and community and state is what they call their Medicaid product. Told me that they're working with, in one housing complex has 7,000 of their members. So they're looking at how they can improve working with the housing authority, how do you improve the health of that group? And specifically, they're looking at things like mold and access to food, and do they even locate a primary care provider there? In your world, it would be, again, I don't know, how do you all assess diabetes literacy? Do your patients and their families understand what diabetes is?
Usually, we talk to them, but the diabetes educators, if you see them and the dietitians, they certainly do a quick thing to find out about diabetes literacy. But in a physician visit, we may ask them a few questions, but I think we don't do it.
Yeah. So, and again, I just know that, Aetna, it's now owned by CVS. Yeah, CVS owns Aetna. They're working, this is a role of, they're looking at the role of pharmacies. I was on a call yesterday around COVID, and Dr. McKinney from Public Health was saying that they're really engaging a lot of pharmacy, that they think they're going to be hiring thousands and thousands of pharmacy techs as part of the vaccination program. This is around the country. And then, is anybody here an expert in artificial intelligence? Oh, good. Then I can appear to be knowledgeable about it. So. Yeah. So this is from Los Angeles, and there's a researcher out of the University of Pennsylvania, Dennis Culhane, who's looking at how do you actually prevent homelessness. So I'm thinking, like, if you have a person with diabetes, how do you actually prevent them from becoming, going into a diabetic crisis? And do you in fact go back and pull in data from their physician notes and use natural language processing to develop a profile? In addition to their clinical indicators and their neighborhood indicators, Humana has a system called Zoom In Now, which actually pulls in neighborhood characteristics. And so the idea is using these artificial intelligence tools to recommend to a provider, so that to have this discussion in regards to shared decision making with the patient and their family about which particular protocol might be there. And again, part of what we're doing, the excitement around United Community, is that it's making those resources available. And as part of that, we're actually, UofL Health Peace Hospital and the Traeger Optimal Aging Clinic are piloting United Community for all of UofL Health to make sure that we in fact can implement it. To give you a sense of this scale, the North Carolina received an 1115 waiver, Medicaid waiver, which basically means that they can design their own program within certain parameters, but they're using the Unitas platform to do this kind of navigation throughout the state. So again, I think for particularly young people in the room, these artificial intelligence tools are really going to, be a tool to help you all in the future.
Similar to the diabetes, like
I don't know. I don't think so. At least I've not seen it yet.
okay.
So. Okay, and again, just a reference to the socioeconomic factors, and I guess we have 20 minutes. I'm not sure if you would like to discuss, hear some more about work that UofL is doing around the state, or to.
One of the questions I have is, say, how does this thing work? Supposing I see a patient in the hospital, who are the people who are kind of involved in these, so that a patient that I see, because I am not dealing with this. We write social worker to see, and
Right.
That's the end of it. And I'm not the one trying to figure this out. So we often find that one of the biggest problems is, yes, we see these people getting repeatedly admitted, the same problems with DKA. Some of them are behavioral, but some of them are socioeconomic. So, but we're not spending too much time trying to figure that out.
Right.
We're just writing our prescriptions. We're just doing the medical part of it. So how do we get from me as a physician seeing the patient to this whole system? Now, how do we understand each other, and who is actually doing all this work?
So I'll give you an ideal scenario. We'll go with that. So in an ideal scenario, what would happen is you would be writing your orders. There'd be all the lab tests and diagnostic tests. That would all, plus the notes from the dietitian, who probably would be able to identify if somebody was food insecure. First, we need to ask the question. Again, one of these studies for the respite program we looked at is, I think, only 44% of the people that were experiencing homelessness were ever asked about their housing status. So people didn't know that they're discharging a person experiencing homelessness, and so naturally you're going to have a higher readmission rate. So again, what you would do is you would go through and you would deliver your clinical care. And again, I don't think that UofL has a lot of at-risk contracts where we're receiving like a capitated payment. So if we were, then that would in fact fund the infrastructure for the technology to go back and aggregate all of that data and then to recommend a plan. I'm very fond of using the term, we want the clinicians to use their clinical gravitas to reinforce a plan that like a case management staff had developed for you. There's a lot of evidence, even in this paper that you referred to me, on the use of community health workers to go out there. because what a community health worker is can help you identify the belief system of the individual. There's some work being done on the medical mistrust. As a matter of fact, we're all, not we all, but I am on a lot of calls these days about, racial discrimination. And one lady in particular goes, I hate going to the doctor because there's such a power differential between it. And so she, delays preventative care. Just a little bit of a aside here, then I'll get back to your question. The other day I was talking to someone, and they said that African Americans believe if you have surgery for cancer, you're going to die. And I'm there, well, that's sort of interesting. But if you go back and actually look at the data, they do not engage in as much preventive services because of this, medical mistrust and implicit bias that they all experience. So there's probably a very high probability that they enter clinical care much later in the process and have surgery. So they probably are much, much sicker when they finally, get to that surgical intervention. So there is a higher probability that they might die. So back to your question though, I would go back and look at constructing a system where the case managers were there. Norton Healthcare is actually incorporating the United Community into their Epic install. So the social workers and case managers will continue to work in the system like they normally would, but then it will, because of it's probably a fast healthcare interoperability resource application program interface, a FHIR APR will send the messages over to the United Community and make the referrals while the person is in the hospital. Again, a key question is having somebody in the hospital ask the questions. And then I would, then there would be this interface to these community health workers who would really follow the people. I think you and I talked once about the pickup for the diabetes self-management education and support programs. It's 10% or less typically. Again, that's where a community health worker would help navigate you into the process. The other thing that we're seeing, I don't think I had a slide on this, but we're actually seeing that payers becoming much more involved in delivery of clinical care. A lot of the Medicare Advantage plans are sending nurse practitioners into patients' home to do the health risk assessments. They're adding home health staff. They're adding, telephonic case managers because, again, they are at risk, and this gets back kind of to the wrong pocket problem that we've encountered. But again, given the current reimbursement structure, it would be a very difficult argument for a hospital to invest as much money as it needs to be invested in that. And part of it too is the research tools. I don't know if Bert Little has ever talked to you. He's a professor in public health, but he got the Medicaid data through a state university partnership, and he can predict people with diabetes that are going to go onto dialysis. I think he says a couple years before they actually start.
Presented it at the
Oh, good.
2 years ago.
Good.
He's
Good.
working with UofL now.
Oh, good.
Project,
Yeah.
I have a question. Thank you for that lecture. It was really fascinating. One thing you mentioned that struck with me was, we prescribe these medications and diets without thinking about patients' ability to do and endurance, but actually afford these things and incorporate them, especially culturally. We prescribe a diet that wouldn't naturally be part of their culture. But do you know of any programs with local, like grocery stores or anything like that, where they do provide some kind of incentive to patients with chronic health conditions to buy more healthy foods? Or do you think that's possible because they have to disclose their diagnosis?
So the one that's closest to it is just starting up now. It's called Next Door Grocery. It's home delivery, and it's founded by, forget her name, but her husband's a physical therapist, and she came to our Community Coordination of Care Committee and described her program, and they're working with UK, to do healthy eating. We're also doing a project in Eastern Kentucky. This is through the Kentucky Diabetes Network, the Partnerships and Networking Committee, where we're looking at food pantry-based interventions and going back, and really the two big initiatives there are, one is to teach the food pantries how to prepare diabetes-friendly distribution, because And again, I always get really leery about saying anything remotely clinical, so keep that in mind. But the dietitians in the group said, if you're going to put 8 cans of vegetables in there, can you put 6 cans of green beans and 2 cans of corn versus 6 cans of corn and 2 cans of green beans? They just don't. The food pantries are not thinking like that, so we're trying to do that. And then the other intervention is to deliver some literacy-appropriate literature on diabetes and healthy eating and exercise activity and things like that. No, but that would be a great project that we would be glad to take on. And again, that's actually an example of, like, do you refer to the next door market? There are 3 efforts underway to start new grocery stores. One is called Feed the West. One is called this Next Door Grocery, and the third is a project of the Louisville Association for Community Economics. It's a grocery co-op, which is a purchasing and a work-around cooperative. And again, the idea there is to those 3 will probably be working together on their supply chain and then serving different markets. One vision that we do have is to connect community agriculture to address the people with food needs, and to reduce any kind of barriers. There's a phrase that we use in public health a lot, like the choices you have are the choices you make. And if you don't have many choices, you're going to eat the stuff, particularly when you need to buy. I have grandchildren that are 3, so my son and his wife spend a lot of money on diapers and stuff like that. So I think about diapers and food and those really basic needs for children quite a bit. Did that answer your question? But that's the kind of thing that we really need. As a matter of fact, there's another really fascinating group, Dr. Stacy Lindow out of the University of Chicago, and she has a group called the Southside Health and Vitality Studies. And one of the things that she talked about is one of the chaplains in University of Chicago's Children's Hospital identified that a lot of parents were asking the nurses for more food on their kids' tray, and then she realized there was food insecurity. So they did she's very fond of the citizen scientist model. So they did a study to really address food insecurity amongst the parents of Children's Hospital. But again, it's a very multifaceted project. She's a great speaker. But she has a program called MAPS, which goes through the south side of Chicago and teaches high school students how to do asset mapping. And an example of that would be like, we see a liquor store and we think, oh, there's another liquor store. Well, it is another liquor store, but they actually sent these students in with adult supervision to document maybe they sell some vegetables there. That's another example of this asset-based approach. And Dr. Lindow is actually a geriatric gynecologist, but her work in the individual seeing patients led her to start thinking about that. And they have developed a no-holder system called NowPal that does referrals and actually does some analysis of the needs using artificial intelligence to do some mapping.
One of the things always being amazed us, like Dr. Mukshidana was mentioning, how much time we spend, and we go back again and again. They come back again and say, oh, your A1C is still high, or you're taking your medicines. And I say, of course I am. And then it took me a year to find out, and this is because patients, they don't want to tell, I don't have this, I don't, have money. Don't hear that from them at all, unless you particularly ask. And even then, they're too proud to ask for help. It took me several months to realize that one patient that I've seen didn't have a refrigerator at home. So here we are giving, and this was before the pen era, insulin pen.
Mm-hmm.
So it's a while, and then it took me a while to process and think that the person doesn't have a refrigerator, which means no fresh food and not able to store insulin vials if they need to. So it was a very humbling experience that I had. So my question is this, which may exist already, just like we have a depression questionnaire. Is there anything that identifies, because ADA, American Diabetes, has been into food insecurity the last few years more than ever before, because we recognize that is a basic problem. If you don't address that, you're not going to get the outcomes that you're looking for over time. Is there a quick, as the triage person is getting the patient, just like we used to ask about domestic violence and this and that, in the diabetes clinics, like a 5 with validated questionnaire that will put you the,
Yes, there's many, and there's actually a group out of University of California, San Francisco called SIREN. It stands for Social Intervention Research and Evaluation Network, and they've done a study of the tools. But the ones that we use here in Louisville are PREPARE, P-A-R-E. The Centers for Medicare and Medicaid Services has these things called accountable communities for health. They have a validated instrument that's 5 mandatory questions. They're interpersonal violence, utilities, food, housing and transportation, I think. So that's a quick one. And then the NIH has one called Phoenix. It's like PHENIX that has these validated tools. Part of what we're pushing is universal screening, which means that I, as a person without resources, don't feel discriminated against because everybody gets asked the same question. We are, and again, I'm always this advocate for UofL Health, taking the lead in all of this work. But part of it would be that you ask everybody that, and that we look for methods which are comfortable for patients. We did a focus group with first I should drop back a little bit and say those areas of food, housing, and transportation were identified by a focus group of community health workers. We just didn't randomly pick that. And you all might want to have a community health worker come talk to you. We have them come talk to the coordination of care committee occasionally. And there are things that, people with resources, it just doesn't cross their mind. For example, in the pandemic, a lot of the housing authorities have laid off their maintenance people. Well, when you lay off a maintenance people and your air conditioner breaks, there's nobody to fix it. So they open up the window and there's no screens, so there's gnats are a problem. I mean, like, who does that? So, but anyway, when we asked this, then we also worked with, again, not me because I can't do everything, but some of our team members went and talked to the Patient Advisory Council of the family health centers. And they told, well, first we were calling it, instead of unmet basic needs, we were calling it unmet essential needs. And the patients told us that we have no idea what you're talking about. The second thing they told us is we are very happy that you're now asking us about this because we think that you are now viewing us as a whole person and not just as a medical widget. And the third thing is they wanted to do it on paper because they felt that that was more confidential versus being asked. So again, if you started doing this universal screening and asking everybody and it was just a few questions, the other thing that they are working on is making sure that we do not want to add, we've heard this over and over again from the clinicians, you cannot add anything else to our clinical time with the patient. So again, if it was some way it was be scored, and again, everybody talks about Epic as the utopian world, but if it could score and then the clinician, could say, I see you score high on your needs assessment, let me refer you to one of our social workers, that you could use your clinical gravitas to reinforce that. I think the quality of care and the outcomes that we have would just increase very, very significantly. And it never, quite frankly, it never struck me that the patient experience would be better because we are now asking about this. So that was kind of like an aha moment for me. Sure.
So one thing is, so making sure you're asking those questions about, people coming into the hospital that they have housing, that they don't experience food insecurity. So if we kind of start asking those questions, like when we're doing an initial consult, other than kind of getting the social worker involved, if you do know any of those issues, you talked about the community health workers, would there be a way of, like, before they leave, also kind of connecting them with another person other than just the hospital social worker?
Yes. So thank you for asking that. So that's kind of the deal. And let me tell you that I know that there's going to be different types of interventions. Okay. So one of those interventions is to tell the person, particularly if they have a Medicare Advantage plan or if they have a Medicare MCO, to please call the provider, the patient, the member line on that and ask what kind of resources are available. A representative from Anthem told me that in one of their plans, they provided $600 a year in transportation benefits. Like, who knew that? Nobody knew it. And then, and again, as the Medicare Advantage plans, there was a change in CMS that allows them to pay more for the social determinant work. So that would be one thing. Call your insurance company. The second thing would be to call 211, which is Metro United Way's call center. And they have people there they're actually social workers based at the Center for Women and Families, who will help navigate people to those resources. And then the third, and this is what the Peace Hospital and Traeger are piloting, is this use of United Community, which means that it's embedded in there. And what it allows, and if you think about all the regulations involved with that in terms of HIPAA and FERPA, which is for the schools. Oh, I didn't say. Jefferson County Public Schools is going to be using this system too. So you now have 100,000 students that will be using the United Community. The patient has to give permission for their need to be broadcast to the network, but it goes out to the network. And one thing that we're tracking is in UofL, we just went on, Traeger just went on it, so we haven't got out, but the United Community director has been tracking this since they went live. Is like right now you can make a referral to a food organization and you never really knew what happened. And so now it gives you a time like, oh, that referral was handled within 3 days, and so the person is not held in limbo anymore. But again, we really need your stories, just like you've expressed about, asking a family about food. I remember years ago at University Hospital, somebody was prescribed a CPAP machine and they lived in a tent. It was like, we just don't think about that. And again, part of it is the blinders that we have on as people with education and resources. So now I have to ask you, what should I be thinking about?
Most all the things we just talked about.
The biggest thing for us, most of us don't know what kind of resources are there, how to access them. So that's the thing that we need from people who are providing this. So that
The past.
when
I was a fellow, before we got the ACA and everything, we used to have a social worker in the clinic, in the AIM clinic in ACA. She was there, and we had patients with all the issues. We used to actually have a.
in fact, in any of our description of so-called, if you want to have a diabetes center, one of the things that you need is social worker. I think, and they should be like the contact person to reach out for all these other things that are there. But as you know, most of the places still,
The cost
it's a cost, and they will think of it as worth it.
she was eliminated because of the. Didn't feel like.
But again, in a hospital system, there is actually some saving in having that because of avoiding readmissions.
Right. Okay. Other things? Again, I'd love to talk to people that are significantly younger than I because you have fresh thoughts and.
Phoenix, and actually I was going to mention that Black and I met them.
Was it Teresa Casey?
Bob said his name was Bob. It was. He was actually. I was very impressed with him. He gave a card, I think, to Zach. So when we had a patient in the university hospital, so it's Phoenix Healthcare. I think they do the homelessness. And I think
They do. Yeah.
And this physician, has worked 20 years ER and then family medicine and a mix in 30 or 40 years, and he looked fairly young, although he gave all this long years of experience. But he then retired and then started doing street medicine. And then when this patient was admitted, which she's a frequent flyer for hypoglycemia, type 1 diabetes, he actually came the day of closer to discharge. He came physically to the hospital, to the bedside to see him. And we luckily were there and we went over his meds. He wrote every one of them. They said, yes, I think I have this insulin. Yes, I think I can give him this. We wrote everything. And I was just amazed. I could not believe it, It was last month, right? I just couldn't get over it that the person, this is like the kind of epitome of a transitional medicine for this homeless patient who was, and he said his name, call me Dr. Bob. So, he works for Phoenix, I think that's
Yeah, they're just right over down the street a little bit from us. So yeah, Andy Patterson, their director, is on the Coalition for the Homeless board with me. So
does Phoenix have, do you have to be homeless? Because I know they give free insulin, but you have to be homeless.
They do.
One of our patients.
Yeah, they have the Family Health Centers has a clinic on East Broadway. So again, if they weren't homeless, but they needed somewhere to downtown, that's where I would recommend them. But again, the two things in terms of resources is really tell patients to call on their insurance card. So the other day we're on this call, this respite to residence call, and the social worker from Peace Hospital presented a case and said, all the work that they're doing with that person, and they said, by the way, we're working to get them disability benefits. And they had said earlier in the call that they were covered by one of the WellCare Medicaid Managed Care organizations, the MCO. And somebody from WellCare happened to be on the same call, so they emailed me and said, will you connect me with that person? Because WellCare has contracted with a company, and the company's sole purpose is to get their beneficiaries who are eligible for disability signed up for disability. So I think that's another example of kind of the connections and the transitions that. As a matter of fact, when we had these complex case conferences years ago, where I still remember this distinctly. So we're sitting there, and somebody presented a case totally de-identified. No names were ever mentioned, but the person from Our Lady of Peace was sitting next to the person from 7 counties, and they realized that they both knew who that individual was, and neither of them knew that the patient was a patient of the other organization. So, okay, so I'm still, we're past time, but I still need some ideas from young people. But young people in the trenches.
I mean, we have a lot. I mean, Lisa does transgender medicine, so.
Yeah, identifying the needs and making the connections, I think, is the biggest thing. If someone identifies a need, knowing where to set the diagnosis. So I think having those resources to give to patients and to help to make them connected, I think, is the biggest thing. Knowing that there are resources is fantastic, but not being able to use them on a clinical patient by patient case.
Okay.
I mean, you can give the card and say, call this person, but if you didn't have a phone to call them, or if they can't hear or not see, then it's a problem. What about all those homeless patients I see when I'm driving down Jefferson and down First Street, and then they're all standing there?
Right.
I mean, I always wondered, how come we couldn't get them a place, or just some of them, like many of these patients are also veterans.
Yeah.
And VA has such excellent programs, but it seems like sometimes patients make a choice not to access programs or be part of groups, and I wonder sometimes what the dynamics of that is. I have possibly had some patients admitted here who are veterans who never use the system, encourage them or lure them into the system. But I feel like it's a great internally in terms of everything.
Right.
I saw something on the news where in Shelbyville, Kentucky, there was, I don't remember like had organized it, but they were building like 8 like tiny homes, which small houses, and it was for like veterans, and it was
It's a beautiful.
basically like for veterans, like to get them on the streets, and it was for so long. And then while they were there, there were people that were working with them to find something permanent like once they left. But that would be something that was.
I think having a place to.
And then getting the resources afterwards once you've gotten like somewhat stabilized to.
Yeah. Well, going for a long time, like I like to do, but thank you. Those are really helpful ideas. And part of it, I think, is just, when we, once there's 1.5 million people covered by the 6 Medicaid managed care organizations in Kentucky. So again, we can encourage them to make sure they know that they're paying for stuff way beyond what a typical person would believe their insurance company would pay for. And for you all to know that too, and we can certainly make sure the social workers and all know to call that. We're telling we train about 40 to 45 social work students at the Optimal Aging Clinic to make sure they know first call should be to the patient's insurance company because it's covered. I mean, lots of stuff's going on there. So thank you.
Thank you very much.
Thank you. That was wonderful.